One of our biggest challenges, of course, in Indian Health Service is underfunding. And if you compare the IHS funding to other sources of federal healthcare expenditures, way on the far right, you see IHS in 2009 was funded at about $2,600 per person per year. Medicare in 2008 was over $11,000. National health expenditure average is $6,700. And Medicaid over $5,000. And even in the Bureau of Prisons, now in 1999 they gave us data. They've not given us data since then because we always compare ourselves to them. But even 10 years ago, the per prisoner medical expenditure is higher than what IHS is today. Isn't that remarkable? And who was born with a legal right to health care? It's American Indians. This is social injustice. This is a civil rights issue. And it shouldn't be acceptable to anyone, whether you're American Indian or not. This is just wrong. And in truth, what would it take to fix that gap? We estimate that IHS, if you compare it to just the federal employee health benefits benchmark, we are underfunded by about 40%. We have about 60% of what we need. The annual appropriation is about $4 billion for IHS. If that were moved to $7 billion, then we would fix that funding disparity. Now, Indian Health Service is part of the Department of Health and Human Services. Health and Human Services is funded at over $800 billion per year. IHS is 4. So to get that other $3 billion into IHS would just be a few tenths of 1% of the HHS budget. So when they say we don't have the money, that's a lie. Because in truth, it's within their budgeting margins of error in the rest of HHS. It's budget dust, essentially, that would fix IHS. Yeah?
Your comment, we have the Bell settlement where the feds were sued because of the management of funds from IM accounts.
Yeah, the question is there potential lawsuit against the feds, just like we had with BIA in the Cobell case for all those many years of mismanagement? And I would say yes. And it's a very easy argument. If you look at these groups of people, they have a legal right to health care. Okay, people on Medicare weren't born with that legal right if you're non-Indian, but eventually you get that legal right. If you're a federal employee, you have a legal right to health care. So on that argument, that what holds these people together legally is that right to health care under federal law. Are we getting equal justice under law? Absolutely not. So there is an unequal justice under law argument for these groups of people eligible for federal benefits. The problem is right now the political climate is so challenging with healthcare. Healthcare is really a political pawn now. It's not, I don't know that the argument is so much about healthcare as much as it is about politics, generally speaking. But yes, there's absolutely a case to be made here. We are not getting equal justice under law, and we have just as much right to health benefits as any federal employee has. But we're not getting that. So yeah, absolutely there would be a case for that. So maybe we'll work on that.
Okay, so the timing right now might not be right, but maybe...
Yeah, even if the timing's not right, maybe it's something we need to consider doing anyway. Yeah.
Let's talk.
Sounds good. Other policy issues in terms of follow-up care, case management, care coordination, pain management. Again, quite often people come home to the reservation community and are prescribed meds that we just don't have in Indian Health Service. So we're very much at a limited capacity to address all of the needs for follow-up care. Minimal access to palliative care, and in South Dakota, we don't have any culturally appropriate hospice services. What a crime. When you think about the deeply rooted cultural and spiritual implications of approaching death, and we don't have any way to address that from a culturally appropriate perspective because of lack of resources, unfortunately.
Well, I think there's only one hospice that's run by tribes in Tohono O Odham.
Yeah, Tio, they have the Archie Hendricks long-term care facility that does include hospice, and they are able to incorporate traditional people with that. So that's a good model that could be potentially replicated. Yeah, Tohono O Odham tribe, Tohono O Odham Nation in southern Arizona has that. And then there's a new long-term care facility at the Cheyenne River Sioux tribe that's about to open up, and they will be developing hospice care, but as of right now, it does not yet exist. All kinds of data and research issues. IHS has their data set. Medicaid has their data set. The state registries have their data set. There's CDC data sets. Are they all as well coordinated as they need to be? Well, no. We're seeing improvements on that front, though. Certainly through the Tribal Chairman's Health Board, we're working with all the states. I think CDC nationally is doing a better job at data cleanup and trying to coordinate those things, but it's quite possible we're still under-reporting because we're not reporting appropriate race or ethnicity with our incidence of cancer. So one of the things that we were able to do is put together a American Indian Cancer Policy Manuscript, a shortened version that was submitted for publication. And then we have a longer version that's intended for tribal leaders to assist in advocacy. And maybe that's an avenue to look at a broader initiative at social justice and Indian health. So we have a background of the issues, overview of the cancer disparities, overview of the policy priority areas, and recommendations for next steps. So this is all under development currently. Now, what about the Patient Protection and Affordable Care Act? What's been called many things. It's been called healthcare reform. It's been called Obamacare, depending on your political persuasion, I suppose. The truth is that this is not healthcare reform. It's health insurance reform. Is Indian Health Service health insurance? No, it's not. So the provisions that are talked about, like increased access to screening, that if you have health insurance, your insurance is now required to pay for screening. Does that apply to contract health services in IHS? No, it doesn't. So it does not impact Indians unless you're on Medicaid, Medicare, or private insurance. Then it will have an impact. But if you're dependent on IHS, it will have no impact. Isn't that disappointing, to put it mildly? Now, part of the Patient Protection and Affordable Care Act is the Indian Healthcare Improvement Act reauthorization. And that finally did get passed. It was only 1 decade late in reauthorization. It was due to be reauthorized in 2000, but finally did get attached to healthcare reform or health insurance reform legislation. So Indian Healthcare Improvement Act does include new things within it, including long-term care services and improvements in public health and disease prevention. But the Indian Healthcare Improvement Act is an authorization to do these things, but it's not a spending bill. So there's no money attached to it. So without funding, it won't be implemented. So that was just the first step, getting it reauthorized. But a reauthorization means now Congress has the authority to spend money on those things that are in the Indian Healthcare Improvement Act. But if they don't put money into it, it won't be implemented. So in practice, it will have no value unless there's money attached to it. Contract health services, there's what's called the CHSDAs, right? Contract Health Services Delivery Area. So if I lived here in Portland and I went to Indian health programs or tribal health programs, am I eligible for a referral for cancer care under contract health? No, I'm not, because I'm not within my CHSDA, my Contract Health Services Delivery Area. I would have to go back to South Dakota to be referred. This happened to my grandmother. She was in her early 80s, and she had unfortunately been a cigarette smoker for many, many years. And she started to get a cough. And we took her to Phoenix Indian Medical Center. They did a chest x-ray, and it was clear that she had lung cancer. She did not have Medicaid. She did not work her 40 quarters. You know, she was to be eligible for Social Security and Medicare. So she had no third-party payer. She was dependent on IHS. So instead of referring her to an oncologist, we had to bring her back to Pine Ridge to get a referral. So while cancer is growing within her, we have to take the time to move back to South Dakota, get an appointment at the IHS facility, wait for a CHS referral, and then try to get her to an oncologist. That delays care. She died from lung cancer without ever having seen an oncologist. Talk about social injustice. And can that happen today? You bet it can. It could happen today. It still happens today.